Okay, let's unpack this. Ever have one of those moments where your brain just feels, well, off? You're trying to concentrate in a meeting, maybe learn something new, but your focus is just fuzzy and the information, it isn't sticking?
Yeah, I think we've all been there to some extent.
Well, today we're diving deep into seizures, and you might be surprised by what we uncover.
That's right. Because when you hear seizure, you might picture, the dramatic shaking, but the reality is much broader, much broader.
Right.
We're talking about a whole spectrum of neurological events that can really, throw a wrench in learning, socializing, everyday life.
Yeah.
Think of it like a sudden temporary blip in the brain's electrical activity.
And this deep dive is inspired by a really crucial issue brought to light in a recent blog post by Dr. Howie Knoff of Project Achieve Educational Solutions. It actually stems from a Supreme Court case, AJTV Osseo area schools. This case, it's centered on a student with severe epilepsy who just wasn't getting the necessary support at school.
Yeah, and it really highlights why understanding these conditions is so vital, especially in education.
Absolutely. This case just underscores the critical need for schools, and really all of us, to better understand and accommodate students with disabilities, and seizure disorders are definitely part of that picture.
For sure.
And if you've ever felt overwhelmed by medical information or just wanted a clear, no-nonsense explanation of a complex topic, you are in the right place.
We hope so.
We're going to break down the different kinds of seizures, what can cause them, and even some, surprising links to stress, trauma, and brain injury.
Yeah, those connections are really key.
Our mission today, inspired by Dr. Knopf's work, is to give you a clearer understanding of the many ways seizures can show up and the real impact they have on people, particularly students.
Okay, so let's get down to brass tacks. What exactly is a seizure?
Good starting point.
Simply put, it's a temporary glitch in how the brain functions, caused by a sudden surge of abnormal electrical activity. It's like a brief electrical storm in the brain cells.
And here's where it gets really interesting. It's so important to ditch the Hollywood image, right, of all seizures involving violent shaking and loss of consciousness.
Oh, definitely. That's a huge misconception.
Because some seizures can be incredibly subtle. Someone might just seem to, zone out for a moment.
Exactly, which can make them really tricky to recognize, sometimes even for the person experiencing them.
And this is more common than you might think, especially with kids.
It is. It's estimated that around 1 in 100 school-aged children experience epilepsy, which, is the condition marked by recurring seizures. Understanding this prevalence is really the first step towards better support.
Wow, 1 in 100. That's a significant number. And Dr. Knopf's blog post really emphasizes that students with epilepsy face a whole host of challenges that go way beyond just the seizures themselves.
Absolutely. Dr. Knopf points out these students are more likely to miss a lot of school, sometimes over 10 days a year.
10 days, wow.
Yeah. They often need specific support outlined in 504 plans or require special education services. And sadly, they also experience higher rates of learning difficulties, as well as anxiety and depression.
And the social side, too.
Oh, yeah. Social stigma and even bullying from peers are also significant hurdles they frequently encounter. It paints a picture of the far-reaching impact of these conditions.
It really does. So let's dive into the different types of seizures. Dr. Knopf categorizes them into two main groups. Focal seizures, which used to be called partial seizures.
I think the terminology changed a bit.
And generalized seizures. Let's start with those focal seizures.
Okay. Focal seizures, like the name suggests, start in one specific area of the brain. Think of it like a localized electrical disturbance.
Just one spot.
Exactly. And within this category, we have two main types. Focal aware seizures, sometimes called simple partial seizures.
Aware.
And focal impaired awareness seizures, or complex partial seizures. Understanding this fundamental distinction about localized brain issues versus, broader systemic factors is key because it dictates how seizures manifest and often points to different underlying causes.
Okay, let's unpack those. So with a focal aware seizure, the person stays conscious, aware of what's happening.
Correct. During a focal aware seizure, someone might have unusual sensations. This could be a tingling feeling in an arm or leg, maybe seeing flashes of light, smelling something that isn't actually there.
Weird.
Or even just having a sudden wave of an emotion like fear or joy. These seizures are usually quite short, lasting just seconds to maybe a couple of minutes, and typically there's no confusion afterward. They just kind of snap back.
That sounds strange, but also relatively contained, like you said.
Yeah.
Now, what about focal impaired awareness seizures? How are those different?
Right, so the main difference here is that these seizures affect awareness. The person might appear awake, but they're not fully in touch with what's going on around them.
So they look awake, but they're not really there.
Exactly. We often see behaviors like staring blankly and repetitive sort of automatic movements. These are called automatisms. Think of little involuntary programs running, like someone fiddling with their shirt or smacking their lips over and over.
Okay. Automatisms.
Yeah. These seizures tend to last a bit longer, generally 1 to 2 minutes, and crucially, they are often followed by a period of confusion.
Got it. So moving on to the second main category, generalized seizures. What makes these different from focal seizures?
Well, generalized seizures involve both hemispheres, both sides of the brain, right from the start.
Okay, so not just one spot.
No, the whole network, essentially.
Right.
Imagine your brain has two halves that usually talk to each other nicely. In a generalized seizure, it's like both halves suddenly start shouting at the same time, electrically speaking.
Okay.
And there's several different types of generalized seizures, each with its own distinct characteristics.
Let's go through them. The first type Dr. Knopf mentions is absent seizures, also known as petit mal seizures. What do those look like?
Absent seizures can be really subtle. They often look like very brief pauses in awareness, maybe like someone's just daydreaming.
Oh, right. Easy to miss then, especially in a classroom.
Very easy.
Eh.
The main sign is a staring spell, which might be accompanied by very slight movements of the eyes or hands, like fluttering eyelids. These seizures are typically short, lasting only about 5 to 30 seconds.
That's quick.
Super quick. And a key thing is that there's usually no confusion afterward. The person can just pick up right where they left off. These are most common in children, which again highlights the need for teachers to be aware.
Then there are tonic-clonic seizures or grand mal seizures. These are probably what most people picture when they think of a seizure, right?
Yeah, these are definitely the more dramatic ones people often associate with the term. They have two distinct phases.
Okay.
First, the tonic phase, where the muscles suddenly stiffen. This can cause the person to fall, and they might even let out a cry as air is forced out of their lungs.
Oh, wow.
Then that's followed by the clonic phase, which involves rhythmic jerking movements of the arms and legs. These seizures usually last between 1 and 3 minutes.
And afterwards?
Afterwards, there's typically a period of confusion, fatigue, maybe a headache, sore muscles. Take some recovery time.
That sounds quite intense. What about myoclonic seizures?
Myoclonic seizures are characterized by very brief, almost shock-like muscle jerks.
Like a sudden twitch.
Exactly, like a twitch or jolt. These jerks can affect just a part of the body, like an arm or a leg, or sometimes the entire body. They're typically very quick, lasting only a second or two, and usually there's no confusion afterward.
And then there are atonic seizures, sometimes called drop attacks. That sounds a bit scary.
They can be, yeah. Atonic seizures involve a sudden loss of muscle tone. Complete loss.
So they just collapse.
Pretty much. This can cause the person to suddenly collapse to the ground, or maybe just have their head drop unexpectedly if they're sitting. These seizures are very brief, usually lasting only seconds, but the risk of injury from the fall is obviously there. Thankfully, recovery is usually quick.
Okay. What about tonic seizures? How are those different from tonic-clonic?
Good question. Tonic seizures involve that muscle stiffening, the tonic part, but without the subsequent jerking, the clonic phase.
Just the stiffening.
Just the stiffening. This can cause a rigid posture, and if someone is standing, it can definitely lead to falls. These seizures are usually short, lasting less than 20 seconds with a brief recovery period.
And finally, clonic seizures.
Right, so clonic seizures are kind of the flip side. They're characterized by repetitive jerking movements without the initial stiffening phase.
Just the jerking.
Just the jerking. These usually affect both sides of the body, last for about 1 to 2 minutes, and are typically followed by a period of confusion.
It's incredible how many different ways a seizure can manifest. Okay, now let's move on to understanding what actually causes these different types and where in the brain they originate. Let's start again with focal seizures.
Sure. Focal seizures, as we said, start in a specific area, and often this is due to some kind of structural difference or abnormality in the brain.
Like what?
This could include things like brain tumors, maybe the effects of a stroke, or scarring that can result from a traumatic brain injury, a PVI. Sometimes they can also be caused by conditions present at birth, like unusual formations in the brain tissue.
Okay.
Dr. Knopf also mentioned something called mesial temporal sclerosis, which is a specific type of scarring in a part of the brain called the hippocampus. This is often linked to a history of prolonged febrile seizures in childhood, which we'll probably touch on later.
Interesting. And the symptoms of a focal seizure really depend on exactly where in the brain it's happening, right?
Precisely. Location, location, location. Dr. Knopf outlines some key connections. For example, the temporal lobe, located roughly behind your temples, is a really common starting point for focal seizures. When a seizure originates here, it can produce those strange feelings of déjà vu, maybe unusual smells or tastes, abdominal sensations like butterflies, and those repetitive movements we talked about, the automatisms.
Right, the lip smacking or fiddling.
Yeah.
What about the frontal lobe located behind your forehead?
The frontal lobe is another frequent starting point. Seizures starting here often involve more obvious motor symptoms, like movements on both sides of the body, sometimes vocalizations like shouting or moaning, and kind of complex body posturing.
And seizures starting in the parietal lobe. That's behind the frontal lobe and above the temporal.
That's right. Parietal lobe seizures tend to trigger sensory disturbances. This could be problems with understanding where your body is in space, spatial perception issues, or feelings of numbness or tingling, usually just on one side of the body.
Finally, the occipital lobe at the very back of the head. I imagine seizures here would affect vision.
Exactly. That's the brain's vision processing center. So focal seizures in the occipital lobe often cause visual hallucinations, seeing lights, shapes, or colors that aren't there, temporary blindness, involuntary eye movements or deviation, and sometimes excessive blinking. It makes sense, doesn't it?
Yeah, it really does, when you link the location to the function. Okay, now, let's talk about generalized seizures. What are the common root causes and brain locations for those?
Unlike focal seizures, which often point to a structural issue, generalized seizures frequently have a stronger genetic component.
Ah, so more hereditary sometimes.
Often, yes. They can be caused by genetic factors like changes in genes that control the electrical activity of brain cells, the ion channels. Dr. Knopf gives examples of mutations in genes like SCN1A or KCNQ2. Think of these genes as tiny electrical switches in the brain.
Right.
When they're not working correctly due to a mutation, it can make the brain more prone to having that electrical storm or seizure. Generalized seizures can also be linked to developmental conditions, metabolic problems.
Like blood sugar issues.
Exactly, or electrolyte imbalances, and also issues with how different parts of the brain communicate and synchronize their activity, especially between that central relay station, the thalamus, and the outer layer of the brain, the cortex.
Thalamus and cortex.
Okay, and imbalances in brain chemicals called neurotransmitters are also key.
Yeah.
Particularly GABA, which normally calms brain activity, and glutamate, which excites it. Getting that balance wrong is often involved.
And the brain involvement is different with generalized seizures, right? It's not just one spot.
No, by definition, generalized seizures involve both hemispheres of the brain right from the start.
Yeah.
Those communication networks between the thalamus and the cortex, the thalamocortical networks, are really central in most generalized seizures.
Why the thalamus?
Well, the thalamus acts like a central switchboard, relaying signals. Abnormal rhythms within these thalamocortical circuits are thought to be the driving force behind many types of generalized seizures.
Are there specific origins within those networks for the different types of generalized seizures we discussed earlier, like absence or tonic-clonic?
There are, yeah. For instance, absence seizures, those brief staring spells, are primarily thought to be genetic, often involving problems with specific types of calcium channels in brain cells. They're associated with a particular pattern of brain activity involving the thalamus and the cortex, especially part of the thalamus called the reticular nucleus.
Okay. And tonic-clonic.
Tonic-clonic seizures can have various underlying causes: genetics, structural issues, metabolic problems, or sometimes the cause isn't even clear. They involve widespread activation across the cortex, as well as deeper brain structures like the brainstem that control consciousness and muscle tone.
What about myoclonic, the jerky ones?
Myoclonic seizures are often genetic and are seen in specific epilepsy syndromes. They mainly involve the motor cortex, the part of the brain that controls movement, and its connections with the thalamus.
And atomic, the drop attacks.
Atonic seizures are often linked to structural brain differences or genetic disorders, like Lennox-Gastaut syndrome. They're thought to involve a sudden inhibition, a quieting, of the motor cortex, leading to that loss of muscle tone.
This is giving me a much clearer picture of the wiring behind these different seizure types. Dr. Knopf also mentions some special seizure types and conditions. Let's start with febrile seizures. These are common in young children, right?
Yes, very common. Febrile seizures are actually one of the most frequent neurological events in early childhood, affecting about 2 to 5% of children between 6 months and 5 years old.
6 months to 5 years. Okay.
And the defining feature is that they happen during a fever, but without any signs of a brain infection like meningitis or any other obvious cause.
So what's the root cause? Is it just the high temperature itself?
It seems to be more about the rapid rise in body temperature, usually above 100.4 degrees A or 38 degrees C, rather than the absolute highest temperature reached.
Ah, the speed of the spike.
Exactly. A child's genetic makeup also plays a significant role. There's a higher chance if there's a family history of febrile seizures.
Yeah.
And importantly, the temperature regulation system in a young child's brain is still maturing.
Makes sense.
Their brains haven't fully developed the robust temperature control mechanisms that adults have, making them more vulnerable to temperature-induced neural excitability. That's why it primarily affects young kids.
And where in the brain did these originate? Is it generalized?
While febrile seizures typically manifest as generalized seizures, affecting both sides of the brain, the initial trigger likely involves temperature-sensitive nerve cells in a part of the brain called the hypothalamus.
The body's thermostat.
Precisely. When a rapidly rising temperature kind of overwhelms the hypothalamus's ability to regulate brain temperature, it can trigger that abnormal nerve cell firing. But the good news is, most febrile seizures are brief and have an excellent outlook. The vast majority of children experience no long-term neurological issues.
That's really reassuring. Now, what about reflex seizures? These are triggered by specific things, right? Like flashing lights.
Exactly. Reflex seizures are fascinating because are reliably brought on by identifiable external sensory stimuli, sights, sounds, or even internal mental activities like reading.
Wow. Unlike seizures that just seem to happen out of the blue.
Right. These have a clear trigger.
What's the underlying cause of this sensitivity? Why would flashing lights trigger one person and not another?
The basic mechanism seems to involve an increased sensitivity or hyperexcitability in specific sensory areas of the brain. So those areas have an unusually low threshold for being activated by certain stimuli.
So they're just more easily set off.
Pretty much. Genetic factors often contribute to this heightened sensitivity, and many reflex epilepsy syndromes actually run in families. When these sensitive brain networks are activated by their specific trigger, they can generate that surge of electrical activity that might stay localized or spread, resulting in a seizure.
Dr. Knopf gives some examples. Photosensitive epilepsy triggered by flashing lights, for instance. Where's that happen?
Yes, with photosensitive epilepsy, the primary area involved is the visual cortex, located right at the back of the brain in the occipital lobe. Flashing lights, certain patterns, or specific visual frequencies, often around 15 to 25 flashes per second, like from a strobe light, or even some video games, can overstimulate these excitable nerve cells. The seizure activity might stay there, causing visual disturbances, or it can spread, maybe leading to a tonic-clonic seizure.
Interesting. And it's more common in teens.
Yes, most common in adolescence, and many people actually outgrow this sensitivity as they get older.
What about audiogenic seizures triggered by specific sounds?
In audiogenic seizures, the main area involved is the auditory cortex, located in the temporal lobe on the side of the head. Specific sounds, maybe sudden loud noises or certain frequencies, can trigger abnormal electrical activity in these sound processing regions.
Could music trigger it?
Absolutely.
Yeah.
A well-known example is musicogenic epilepsy, where specific pieces or even genres of music can trigger seizures for some individuals. Sometimes the seizure might initially show up as hearing things that aren't there before progressing.
And reading epilepsy, that sounds really specific.
It is quite specific. In reading epilepsy, the primary area usually involved is in the language centers of the brain, typically in the temporal and frontal lobes of the dominant hemisphere, which is usually the left side for most people.
So the act of reading itself.
Yes, the complex process of reading involving visual processing, understanding language, maybe even the physical act of silently speaking the words to yourself can overwhelm these susceptible brain circuits. Interestingly, these seizures often start with maybe a jaw jerk or a strange sensation in the throat before potentially becoming more widespread.
Wow.
It's a really interesting example of how complex mental activities can link to epilepsy. Dr. Knopf also mentions other reflex triggers, like eating, involving the temporal lobe, being in hot water, maybe involving the parietal lobe, even complex tasks like math or making decisions, potentially involving the frontal lobe.
So managing these involves avoiding the trigger.
Yeah, avoiding the specific triggers as much as possible is key, along with using targeted anti-seizure medications sometimes.
The brain is so interconnected. It's fascinating how these specific things can set off a seizure. Now, the last special condition Dr. Knopf discusses is status epilepticus. This sounds very serious.
Yes, status epilepticus, or SE, is absolutely a medical emergency. It's defined as either a single seizure that lasts longer than 5 minutes
5 minutes, so cool.
or a series of seizures that occur close together without the person regaining full consciousness in between. It's a very serious situation with significant risks.
What are the primary root causes? Why would a seizure just keep going?
Well, the fundamental issue in status epilepticus is that the brain's normal mechanisms for stopping a seizure fail. Usually there are natural braking systems that kick in. In SE, these systems aren't working correctly, allowing that abnormal electrical activity to just continue.
What can cause that failure?
Several specific things. One major cause is suddenly stopping anti-seizure medications in people who already have epilepsy. That's a big one.
Right.
Acute brain injuries like a TBI, stroke, brain infections, lack of oxygen to the brain can also disrupt the brain's normal electrical balance and lead to prolonged seizures. Metabolic problems like severe imbalances in electrolytes or kidney or liver failure can affect brain function and make seizures harder to stop. And finally, some progressive neurological conditions like certain brain tumors or neurodegenerative diseases can sometimes manifest as status epilepticus.
And how does this manifest in the brain? Are there different patterns depending on the type of SE?
Yes, the brain involvement really depends. In convulsive status epilepticus, which is what most people think of with the prolonged shaking, there's widespread, continuous, abnormal electrical activity throughout both sides of the cortex, leading to those visible convulsions. But in non-convulsive status epilepticus, the outward signs might be more subtle, maybe just a prolonged state of confusion or altered awareness, without the prominent motor stuff. This can involve more specific brain regions, particularly in the temporal and frontal lobes.
And focal SE.
Right. Focal status epilepticus remains limited to a specific area of the brain, depending on the underlying cause, like a stroke or tumor, just in that region.
Dr. Knopf also mentions a progression of status epilepticus through different phases. Can you explain that? It sounds like it gets worse over time.
Yes, it generally does. There are recognized stages. The initial phase, maybe the first 30 minutes, involves intense nerve cell firing, but the brain's natural seizure-stopping mechanisms are still somewhat effective, and it's generally more responsive to initial treatments, like benzodiazepines.
Okay.
Then you have the established phase from about 30 to 60 minutes. This is when those natural mechanisms start to really break down. The brain cells become less responsive to the usual calming signals, making the seizures much harder to stop with standard treatments.
And beyond an hour.
That's often considered the refractory phase. This involves significant changes at a cellular level, potential energy failure in brain cells, brain swelling, systemic complications affecting other organs. This phase requires very aggressive treatment, often including anesthesia. It's critical to understand that the longer status epilepticus goes on, the more resistant it becomes to treatment, and the greater the risk of permanent brain damage and other severe outcomes.
That really underscores why it's such a serious medical emergency. Okay, let's shift gears a bit now. Dr. Knopf also discusses the intricate relationship between seizures, stress, and PTSD. This sounds like a really important connection to understand.
It absolutely is, and the relationship is actually a two-way street, a bidirectional impact.
Oh, so?
Well, stress and post-traumatic stress disorder can definitely trigger or worsen seizures in people who are already prone to them. We hear this a lot from patients.
Stress is a trigger, okay?
But on the flip side, experiencing seizures can be a traumatic event in itself. It can lead to significant psychological stress and potentially contribute to the development or worsening of PTSD symptoms. It's estimated that for a significant portion of people with epilepsy, maybe 30% or more, stress is a major trigger for their seizures.
How does stress, on a biological level actually influence seizure activity? What's happening in the brain?
Stress affects the brain through several pathways. When we're under stress, our bodies release hormones like cortisol. These stress hormones can actually lower the seizure threshold in susceptible individuals.
Make it easier to have one.
Exactly. They can make brain cells more easily excitable and disrupt the normal electrical balance. Plus, chronic stress often leads to poor sleep, and we know that sleep deprivation is a well-established trigger for seizures because it also increases brain excitability.
Right, sleep is huge.
Huge. Additionally, acute stress can sometimes lead to rapid breathing or hyperventilation, which can cause changes in blood chemistry, specifically CO2 levels, that might provoke certain types of seizures in some individuals.
Okay, so stress can be a trigger, but you also mentioned that seizures themselves can contribute to PTSD. How does that happen?
Well, think about it. Seizures can certainly be very traumatic events. They can be incredibly frightening, involve a loss of control, maybe injury. This can create a sense of helplessness and vulnerability.
Yeah, I can imagine.
The unpredictability is a big factor too, always worrying about when the next one might occur. Experiencing a seizure in public can be extremely embarrassing and isolating, leading to social anxiety. Even the confusion and disorientation, the postictal state that can follow a seizure can be a scary experience in itself.
So all that can build up.
Exactly. All of these factors can contribute to the development of what's sometimes called seizure-related PTSD. This might involve persistent worry about future seizures, anticipatory anxiety, intrusive memories, or even flashbacks of past seizure experiences, avoiding situations that might trigger a seizure or where having one would be particularly bad, and a state of hypervigilance, constantly being on alert for any bodily sensation that might signal an oncoming seizure.
Wow, that sounds like a really difficult cycle. Stress triggers seizures, seizures cause more stress.
It can create a really challenging cycle, absolutely.
Dr. Knopf also mentions that PTSD has been linked to specific types of seizures, including something called Psychogenic Non-Epileptic Seizures, or PNES. What's that connection?
Yes, that's a really important point. Research has shown that a significant number of individuals with PNES, somewhere between 25 and 40%, maybe even higher in some studies, have a history of PTSD or other significant trauma.
Okay, so what are PNES? You mentioned non-epileptic.
Right. PNES, as we'll discuss in more detail, are episodes that look very much like epileptic seizures, shaking, loss of awareness, etc. But crucially, they are not caused by abnormal electrical activity in the brain. The cause is believed to be psychological, often linked to underlying stress or trauma.
So the PTSD link makes sense there.
It does. The ongoing state of heightened alertness, the hyperarousal that's common in PTSD, can keep the brain and body in a more reactive state, potentially making someone more vulnerable to these kinds of dissociative or conversion-type events. Sleep problems, also common in PTSD, can lower the overall threshold. And sometimes intense emotional experiences or the re-experiencing of traumatic memories, like in a flashback, can directly trigger these PNES episodes.
So stress can worsen actual epileptic seizures, and it's linked to these non-epileptic ones.
Exactly. Dr. Knopf points out that in people who already have epilepsy, PTSD and chronic stress can lower their threshold for epileptic seizures, potentially leading to more frequent focal or generalized seizures. And then there are dissociative seizures, which are generally considered a type of PNES, often linked to how the brain processes trauma involving changes in awareness, motor symptoms, sensory disturbances. The key takeaway here is that the connection between stress, PTSD, and seizures, both epileptic and non-epileptic, really emphasizes the importance of comprehensive treatment that addresses both the neurological and the psychological aspects. You can't just treat one without considering the other.
This brings us squarely to that term Dr. Knopf uses, PTSD, or stress-induced psychogenic non-epileptic pseudoseizures, or PNES. You said they look like seizures but aren't electrical. This sounds really complex.
It is very complex and often misunderstood. As we touched on, PNES are episodes that can mimic epileptic seizures quite closely, but when the brain's electrical activity is measured with an EEG during an event, there are no corresponding abnormal patterns that define an epileptic seizure.
And the trauma link is strong.
Very strong. It's estimated that a large percentage, maybe 50 to 80%, of people diagnosed with PNES report a history of significant trauma or abuse, often starting in childhood. And the condition is indeed much more common in individuals who also meet criteria for PTSD.
What's the underlying mechanism thought to be? How does trauma lead to these seizure-like episodes if it's not electrical?
Well, it's still being researched, but the thinking relates back to what we know about PTSD's effects on the brain. PTSD involves significant changes in brain function, particularly in areas that regulate our response to stress and threat. The amygdala, fear center, the hippocampus memory, the prefrontal cortex, emotional regulation. These neurobiological changes can create a state of heightened physiological arousal, sort of like the body is stuck in fight or flight. In some individuals, this chronic state of internal distress or the sudden re-experiencing of traumatic memories can manifest physically as these seizure-like episodes. It's generally understood not as a conscious act, but as the brain's way of coping with or expressing overwhelming emotional distress when other coping mechanisms are overloaded. It's sometimes described as a type of conversion or dissociative phenomena.
So what are some of the characteristics that might help differentiate PNES from epileptic seizures? Clinically, how might they look different?
There are some features doctors look for. though diagnosis really requires video EEG monitoring to be certain.
Sure.
PNES episodes are often triggered by recognizable emotional events or internal conflicts, rather than physiological triggers like sleep deprivation. They might build up more gradually, whereas epileptic seizures often start very suddenly. The intensity of a PNES episode might fluctuate, wax and wane, and the movements can sometimes appear more asynchronous, less rhythmic, maybe involving side-to-side head shaking or pelvic thrusting, which are less typical for epileptic seizures. Interestingly, during a PNES episode, the person's eyes are often tightly closed, whereas in many convulsive epileptic seizures, the eyes are open.
That's a specific detail.
It can be a clue. Also, individuals experiencing PNES might retain some level of awareness or respond to verbal cues or touch during the event, which is unusual for a generalized epileptic seizure. They typically recover more quickly afterward without that prolonged period of confusion, the post-ictal state, seen after many epileptic seizures. And finally, PNES episodes often last longer than typical epileptic seizures, frequently going on for more than 2 minutes, sometimes much longer.
It's really important to emphasize, as Dr. Knopf does, that people experiencing PNES are not faking it. Their distress is absolutely real.
Absolutely crucial point. The disability and suffering caused by PNES are immense and very real. This is not malingering. And complicating things further, it's important to remember that a significant minority, somewhere between 10 and 30% of people with PNES, also have coexisting epilepsy.
Wow, that makes diagnosis incredibly challenging.
It really does. Requires careful evaluation, usually in specialized epilepsy monitoring units.
So what are some of the common symptoms someone experiencing a PTSD-induced pseudoseizure, or PNES, might actually exhibit during an event?
Well, common symptoms include that uncontrollable shaking or trembling, which can affect the whole body or be localized. As we said, unlike many epileptic seizures, the individual is often conscious and somewhat aware of their surroundings, even if they can't respond verbally.
Feeling detached, maybe.
Yes, people often report feeling detached or foggy during these episodes, rather than being completely unconscious. Other physical symptoms can include rapid breathing, increased heart rate, sweating, signs of that physiological arousal, and various sensory disturbances like tingling, numbness, or changes in vision or hearing, either before or during the episode. And again, the key diagnostic factor is that EEG testing during a PNES event typically doesn't show those characteristic epileptic brainwave patterns.
What are some of the underlying causes and risk factors that might make someone more susceptible to developing PNES, particularly linked to PTSD?
Several factors seem to increase the risk. The severity and duration of the trauma itself are significant. Individuals who have experienced prolonged or repeated trauma, like survivors of childhood abuse, combat veterans, or refugees, appear to be at higher risk.
Pre-existing conditions.
Yes, certain pre-existing conditions might also increase vulnerability. Things like a history of prior traumatic brain injuries, maybe a history of actual epileptic seizures in childhood, and potentially even genetic factors that influence how someone's body and brain respond to stress.
And the person's current situation.
Absolutely. Social and psychological factors play a crucial role. Limited social support, ongoing stressors in life, financial worries, relationship problems, and co-occurring conditions like depression, anxiety disorders, or substance use disorders can all worsen both PTSD symptoms and the likelihood of experiencing PNES.
Given this complexity, what are some of the treatment approaches for PTSD-induced pseudoseizures? It sounds like it needs more than just medication.
Oh, definitely. Effective management really requires a comprehensive, multifaceted approach, often involving a team. Psychotherapy is usually central, particularly trauma-focused cognitive behavioral therapy, or TFCBT.
How does that help?
It helps individuals process their traumatic memories in a safe way, challenge unhelpful thought patterns related to the trauma, and develop healthier coping skills. This can reduce the emotional intensity that often triggers the PNES episodes. Eye movement desensitization and reprocessing, EMDR, is another therapy that's shown promise.
Right. EMDR for trauma.
Yes, it seems to help the brain reprocess traumatic memories, which can reduce both PTSD symptoms and, in some cases, the frequency of PNES.
What about medication? You said anti-seizure meds don't usually work.
Correct. Traditional anti-seizure medications aren't effective because the underlying mechanism isn't epileptic. However, medication management can still play an important supportive role. SSRIs and other antidepressants can help manage underlying PTSD, anxiety, or depression, which can indirectly reduce PNES frequency by lowering overall distress. Sometimes anti-anxiety medications might be used cautiously, short-term, during periods of acute stress, but long-term use is generally avoided.
Any other approaches?
Yeah, relaxation techniques like biofeedback, Deep breathing exercises, progressive muscle relaxation can be very helpful. They can help individuals learn to recognize early warning signs of distress and use skills to regulate their physiological arousal, potentially preventing or lessening episodes. And finally, good communication and care coordination among neurologists, psychiatrists, psychologists, primary care doctors, and other providers are absolutely essential to ensure all aspects of the condition are appropriately addressed and the person doesn't fall through the cracks.
It really sounds like awareness and support are just crucial for individuals experiencing PNES. It sounds like they face a lot of misunderstanding.
They really do. Despite growing understanding in specialized centers, many individuals still face significant challenges in getting the correct diagnosis and appropriate treatment. Misdiagnosis as epilepsy, leading to ineffective and potentially harmful medication trials, is still common. Or worse, sometimes symptoms are dismissed as just psychological or attention-seeking, which is incredibly invalidating.
So education is key.
Vital. Raising awareness among healthcare professionals, educators, first responders, and the general public is so important. For students in particular, having supportive teachers, counselors, and school nurses who understand PNES can make a huge difference. They can provide validation, help develop practical coping strategies, offer accommodations, and just foster an environment where the student feels understood and not alone.
Okay, shifting focus slightly again, Dr. Knopf also delves into the connection between seizures and traumatic brain injuries, or TBI, another really important link.
It is indeed. There's a well-established link between TBI and the subsequent development of seizures, and it varies depending on factors like the severity and location of the brain injury, as well as individual factors. We talk about post-traumatic seizures, or PTS.
And they're classified based on timing.
Yes, that's right. Immediate or impact seizures happen right at the moment of the injury. These are actually relatively uncommon and, interestingly, aren't strongly associated with the later development of chronic epilepsy. Then there are early post-traumatic seizures, which occur within the first 7 days after the injury. These are more frequent, especially after more severe TBIs, and are often seen as an acute reaction to the brain injury itself, the swelling, the bleeding, the immediate chemical changes.
And late seizures.
Late post-traumatic seizures occur more than a week after the injury, could be months or even years later. The occurrence of even one late seizure is often considered diagnostic for post-traumatic epilepsy.
So what exactly is post-traumatic epilepsy, or PTE? How's it different from just having a seizure soon after injury?
Post-traumatic epilepsy, PTE, refers to the development of recurring unprovoked seizures as a chronic condition following a TBI. It's not just the immediate reaction, it's a lasting change in the brain that makes it prone to seizures ongoing.
And the risk depends on how bad the TBI was.
Very much so. The likelihood of developing PTE is strongly correlated with the severity of the initial brain injury. For mild TBI, like a concussion, the risk is generally quite low, maybe around 1 to 2%, although some studies suggest it might be higher with multiple concussions.
Okay. Moderate TBI.
Moderate TBI carries a slightly higher risk, perhaps around 2 to 4% within the first 5 years. But severe TBI presents the highest risk. Estimates range from 10 to 20%, and it can be as high as 50% in cases involving penetrating injuries to the brain, like a gunshot wound.
Yeah.
And importantly, the risk remains elevated for at least 10 years, possibly longer, after a severe TBI.
Are there specific risk factors beyond just severity that make someone more likely to develop PTE after a TBI?
Yes, there are several factors related to the injury itself that increase the risk. These include penetrating brain injuries, as I mentioned, bleeding inside the skull, intracranial hemorrhage, bruising of the brain tissue, contusions, skull fractures, especially those that are depressed or require surgery, having those early post-traumatic seizures within the first week.
So an early seizure predicts later ones sometimes.
It's a significant risk factor, yes.
Okay.
Also, a loss of consciousness lasting longer than 24 hours, and a low score on the Glasgow Coma Scale initially, which indicates a more severe injury.
Are there patient-related factors, too?
Yes. Age is a factor, with higher risk in very young children and older adults over 65. A family history of epilepsy might slightly increase risk. Any pre-existing brain conditions could play a role. And heavy alcohol use is also considered a risk factor.
What are the actual mechanisms? How does hitting your head eventually lead to recurring seizures maybe years later? Is it an immediate process or does it evolve?
It's definitely a process that unfolds over time, often called epileptogenesis, the generation of epilepsy. It's complex and involves multiple stages.
Okay.
In the initial acute phase, the first minutes to days after the injury, you have immediate changes like altered neurotransmitter release, too much excitatory glutamate, maybe not enough inhibitory GABA, problems with ion channels in nerve cells, a breakdown of the protective blood-brain barrier allowing potentially harmful substances in, and brain swelling or edema.
That sounds like chaos in the brain.
It is, acutely. Then, during the subacute phase, lasting from days to weeks, other processes become important. Neural inflammation, the brain's immune response, kicks in, but it can sometimes be excessive or prolonged, causing further damage. Oxidative stress from free radicals, damage to the nerve fibers or axons, and changes in blood flow within the brain also contribute during this period.
And then the long-term changes, the chronic phase.
Right. In the chronic phase, which can last for months to years, more permanent structural and functional changes occur. You can get abnormal rewiring of neuronal circuits connections forming where they shouldn't. Scar tissue formation, called gliosis, can disrupt normal function. There can be changes in the inhibitory circuits that normally help prevent seizures, making them less effective. Ongoing problems with the blood-brain barrier might persist. And even changes in gene expression can occur, leading to long-lasting alterations in nerve cell excitability that make the brain susceptible to spontaneous seizures. It's a cascade of events, really.
It sounds like a long and complicated road from injury to epilepsy. So, given all these different types of seizures and their connections to stress, trauma, and TBI, what are some of the general management approaches? Let's start back with PNES and stress-related seizures. How are those typically managed?
Right. For PNES and seizures clearly linked to acute stress, the main focus, as we discussed, is on psychological treatments. CBT, especially trauma-focused CBT, if PTSD is present, is often first line. Stress reduction techniques, mindfulness, progressive relaxation are key. Therapies that address trauma directly, like EMDR, can be very helpful. Biofeedback can help people gain control over physiological responses.
And medication.
Medication plays a supportive role, mainly treating the underlying psychological conditions like anxiety or depression with antidepressants or sometimes short-term anxiolytics, always under careful medical supervision. Lifestyle changes are also really important. Prioritizing regular, good quality sleep, practicing consistent stress management techniques like exercise, sometimes keeping a seizure diary to identify patterns and triggers, and engaging with support groups can be very beneficial.
Okay. And what about the management of post-traumatic seizures and actual post-traumatic epilepsy?
It's a bit different. In the immediate aftermath of a moderate to severe TBI, doctors might prescribe anti-seizure medications prophylactically, meaning preventatively, usually for about 7 days. The goal is to prevent those early post-traumatic seizures.
Does that prevent long-term epilepsy?
Unfortunately, current evidence suggests that this short-term preventative treatment doesn't significantly reduce the risk of developing late seizures or chronic post-traumatic epilepsy down the road.
Ah, okay. So what about when someone does develop PTE?
For established post-traumatic epilepsy, the management is similar to other forms of focal or generalized epilepsy. The mainstay is treatment with anti-seizure medications, or ASMs. Commonly used ones include drugs like levetiracetam, carbamazepine, lamotrigine, valproic acid. The choice depends on seizure type, side effects, other medical conditions, etc.
What if medications don't work?
For individuals with focal PTE whose seizures don't respond well to medications, what we call drug-resistant epilepsy surgical options might be considered. If the seizures consistently originate from a specific, identifiable, and safely removable area of the brain, epilepsy surgery can be very effective. Other options include neuromodulation techniques like vagus nerve stimulation, VNS, which involves implanting a device similar to a pacemaker to help regulate brain activity.
Lots of different strategies depending on the type and cause. Finally, Dr. Knopf really emphasizes the crucial role that schools play in supporting students with seizure disorders. This ties back to that court case, too. What are some of the key things schools need to have in place?
Schools are absolutely vital partners in ensuring the safety, academic success, and overall well-being of students with epilepsy and other seizure disorders. It's not just about academics, it's about safety and inclusion.
And there are legal requirements too, right?
Yes. Many states now have laws, sometimes called seizure-safe schools legislation, requiring schools to provide training for staff on recognizing seizures and providing appropriate first aid. They also often mandate having individual seizure action plans in place for affected students and protocols for administering prescribed rescue medications, like Diastat or nasal sprays.
So what are the key practical strategies for schools?
Well, first and foremost is close communication and collaboration. That means ongoing dialogue between the school administration, the school nurse, teachers, counselors, the parents or guardians, the student themselves when appropriate, and their medical specialists. The school's MTSS team, or 504 IEP team, often coordinates this.
Trained personnel are key too, I imagine.
Absolutely. Having nurses or other designated school personnel who are trained and available to administer any prescribed rescue medications is crucial. They also need to be able to monitor students who have frequent seizures or specific health concerns. And it's not just the nurse. All school staff who interact regularly with the student, including bus drivers, cafeteria workers, classroom aides, coaches, need to be informed about the student's condition and trained on how to respond appropriately to a seizure.
What about the other students? Peer awareness.
That's a really important piece. Providing age-appropriate education for classmates can help reduce stigma, prevent teasing or bullying, and encourage peer support and understanding. Some schools even incorporate basic epilepsy education into their health curricula.
And the formal support plans.
Yes. Determining if a student is eligible for accommodations under Section 504 or requires specialized instruction and related services through an individualized education program, IEP, is critical. These plans address not just the medical management, but also any academic challenges, social emotional needs, and requirements for related services like occupational therapy or counseling. They outline necessary accommodations, like extended time for tests, preferential seating, or rest breaks.
And the Seizure Action Plan itself.
That's the cornerstone for immediate response. A clear, concise seizure action plan developed with the parents and medical team should be readily accessible to relevant staff. It needs to outline specific first aid steps for that student's seizure types, list known triggers to avoid if possible, provide emergency contact information, detail emergency procedures, and give clear instructions on if, when, and how to administer rescue medications. Having this plan is so important to support students effectively and ensure they have equal access to education and school activities safely.
This has been an incredibly insightful deep dive into the complex world of seizures. Just to recap some key things, we've learned that seizures are remarkably diverse. So many different types, varied causes, and a wide range of impacts on individuals.
Definitely not a one-size-fits-all condition.
And we've explored the significant and often interconnected links between seizures and stress, trauma, and traumatic brain injuries. Understanding these connections seems absolutely crucial for providing effective support, especially in educational settings like Dr. Knopf's blog and that AJT case really highlighted.
That's right. And it's so important to remember that for individuals experiencing seizures and these related conditions, addressing both the neurological and the psychological factors through comprehensive integrated care is just vital. It's essential for improving their quality of life and overall well-being.
And finally, the proactive role of schools and communities just cannot be overstated, can it? Creating supportive environments, providing proper training to staff and students, fostering a general understanding and empathy around seizure disorders, it can make such a profound and positive difference in the lives of those affected.
It really can. And perhaps this raises an important question for you, the listener, to consider. Given the complex ways the brain, the body, and our environment and experiences interact in conditions like seizures, what other invisible neurological or psychological experiences might we be overlooking? And how can we, as individuals and as a society, do a better job of understanding and supporting those who are living with them? It's definitely something to think about.